our next speaker, I'm not sure, is our next speaker coming in remote? This is Charita Joshi is coming in, and she's actually going to address a question that you just asked, Jackie, about the different types of neuromodulation. So her talk title is actually Intracranial Neuromodulation, DBS, RNS, and LGS. So she'll be looking at those different types. So with that, I think if we can get her, hey, Dr. Joshi, it's great to see you. Welcome. Thank you for being here remotely. We can't wait to hear from you.
Thank you so much. I hope you can hear me. If you can't, just say so. And thank you for not only inviting me, but I'm on call. I'm in Dallas, UT Southwestern. And therefore, this is a great opportunity that I can speak to all of you via Zoom. Good morning, good afternoon, wherever you may be. The title of my talk is Intracranial Neuromodulation. I do not have any disclosures that are relative to this talk. And so why neuromodulation and when neuromodulation? And I know that Dr. Morel just introduced the topic of responsive neuromodulation to you, also called RNS. But everybody knows about the study that was published almost 25 years ago by Brody and Kwan that looked at 470 patients with previously untreated epilepsy. I hope you can see my mouse. And out of these 470 patients, when patients were given the first medication, only 47% responded and remained seizure-free. When they were given the second medication, 13% responded. And then by the time you come down to the third or the fourth medication, the response rate is less than 4%. And therefore, at this point in time, it is very commonly accepted practice that irrespective of a patient's age, when they have failed 2 medications that are appropriately chosen, they should be referred to a specialized center for epilepsy to see if there are other options. And those other options could be seizure medications in a pharmaceutical trial, perhaps, maybe dietary therapy, maybe resective therapy, or ablative therapy like laser, disconnecting type therapy like corpus callosotomy that perhaps some of your children have had, genetic therapy if there is a particular genetic condition. The problem with these therapies, and if you look at the right side of my screen, you cannot resect if there is not a uniform focus that is not in a critical area of the brain, which if removed will make a child crippled perhaps, or if there are multiple foci and you typically do not want to just go woodpecking all over, or if it is a network disorder, like a developmental and epileptic encephalopathy, like LGS, is considered a network disorder where the network is too broad to be able to do precise resection or precise ablative surgery. So the history of neuromodulation is quite old. And in 1973, cerebellar neuromodulation was tried by Cooper. We have neuromodulation across the brain in the cortex, which is the superficial layer of the brain, as well as in the deeper structures in the basal ganglia. There are 2 main ideas behind neuromodulation. One, if I have a focus, as Dr. Morel was speaking, there is a focus, a seizure is detected, and the seizure is zapped. And we know that when we do EEG studies or invasive EEG studies, when I'm doing brain mapping, depending on the current and the frequency, if I see after discharges and I zap it at that same frequency, sometimes all those after discharges disappear. So that's one theory. The second theory is that sometimes if you zap, I'm using the word zap in a very loose way, if you do electrical stimulation of a critical area in that network, then the epilepsy can also respond. So there are 2 different ways to think about neuromodulation. One is open loop neuromodulation, like the vagus nerve stimulator, which is extracranial, outside the brain, or the deep brain stimulator that is inside the brain. And open loop means that no matter what, 24/7, you will get current at a certain program, 30 seconds on, 5 minutes off, certain frequency, certain pulse width, certain amperage. So one of the first studies on this DBS and neuromodulation in Lennox-Gastaut syndrome came in the very early 1900s from Velasco in Mexico City, and then they published their data in 13 patients. This study in 13 patients that had Lennox-Gastaut was not allowed to be double-blind. The reason is that all these patients were really sick. And as you can see in this table, the youngest child was 4 years old. The majority of these children are 13 or less. And as you can see, they had thousands of seizures per month. If you can see my mouse, and many of them had liver failure from the medications they were on. One of the child even had pancreatitis. So once again, an extremely sick group of patients that was having a lot of seizures on a daily basis. What the Velasco group did is that they implanted with techniques that were available at that time. We didn't have high quality MRIs, as Dr. Morel had mentioned earlier at the time, and they had used ventriculography and stereotactic neurosurgeons or functional neurosurgeons had put bilateral electrodes into the centromedian nucleus of these patients and then started therapy and watched these kids over 18 months. If you look at the left side, the patients, this is total seizure count. If you look at the group total seizure count over time, and it took about 5 months for them to see 80% improvement, as you see in the top panel here, seizures went down from 2,000 a month to less than 500 a month. If you looked at the generalized tonic-clonic seizures, once again, there was a remarkable response as compared to atypical absence, where the response is not good, but nevertheless, it is better than 80%. What these researchers did is that they not only confirmed the stereotactic placement by doing postoperative scans, but also electrophysiologically looked to make sure that the electrodes were in the correct place. And patients that had a greater response obviously had correct implantation, both at a neurophysiological level as well as at an MRI level. And as Dr. Morel had told you earlier, the centromedian nucleus is really tiny for a surgeon to target, but with advanced MRI techniques, it is possible to do. And then 16 years after the Velasco publication came out the first randomized double-blind trial of deep brain stimulation of the thalamic centromedian nucleus. And this is called the Estell trial, which stands for Electrical Stimulation of the Thalamus in Epilepsy of the Lennox-Gastaut type. And this study came from Dr. Dalek and colleagues. Who were these patients? Now, as compared to the Velasco study, the majority of these patients were older. So the average age of the patient, all of these had Lennox-Gastaut syndrome, they had tonic seizures, they had the EEG characteristics, but the mean age at implantation was 25 years. As you can see in this box, these people had big seizures, tonic-clonic seizures, drop attacks. The majority of these patients were on at least 3 medications. And look at the monthly number of seizures that they have. They have 79 generalized tonic-clonic or tonic seizures per month. So once again, everybody's seizing several times a day. The researchers had noted that they would require at least 10 patients in each group. So for this type of a device trial, you don't need hundreds and hundreds of patients, but 10 patients per group. I am going to try and explain this trial to you. Forget that top part. But if you look at the bottom part in B, initially for the first 3 months, everybody's counting seizures in their seizure diaries. Then all the patients that agreed to participate got implanted with the deep brain stimulator into the bilateral centromedian nucleus of the thalamus under direct MRI guidance. Then for the first 3 months, this is pre-stimulation 1, 2, 3. Nobody gets any stimulation at all. And then half the patients get on, but they are blinded. Only the person that is stimulating them knows what is happening. And half the patients are not blinded. So it's sham stimulation. And this happens for 3 months. And then from 3 months to 6 months, once the stimulation has started, patients come back and get unblinded and go on to an unblinded section. So the whole study really lasted a total of 9 months. But out of that, starting with the surgery procedure, you have about 9 months of study. I'm going to explain each of these graphs. So if you look at the median seizure reduction, the blue is the patients that were going to get the real treatment. Gray is the patients that did not get treatment. So you might wonder, how come after surgery, everybody's seizures dropped? This is called the implantation effect. And it is thought that perhaps the lesion that gets made into the deep structures is stunning that network, and that's why the seizures drop. Then in the patients that did not get treated, the seizures start to creep up. While the patients that got treated at 3 months in the blue, the seizures keep trending down. And this is even more observable at the time unblinding happened, where the patients that were in the sham started to get treatment. Look at how quickly their seizures drop here. And then the patients that were already treated continued to drop. But remember that the number of months of follow-up as compared to the Velasco study is less, because what these researchers did is that they wanted diary number of seizures during the time that the blinding occurred to the time that blinding ended. So between 3 to 6 months. So they have a really narrow window when they are looking to see if there was effect. Now, in the next panel B, you have median seizure reduction by EEG. These patients also got EEG to look at how much of paroxysmal fast activity there is on EEG. And as you can see, because of the implantation effect, everybody's EEGs improved a bit. The EEGs in the blinded side, they continued to worsen or show electrographic seizures, whereas patients that got treatment continued to improve to a larger degree on EEG compared to how well they did clinically. If you look at the median reduction by individual, there were 19 patients in total. This study occurred between 2017 and 19. And so in these 19 patients, there was one patient whose seizures apparently worsened by their seizure diary, but overall mean reduction was that of 46.9%. This was not statistically significant over a 3-month period, but clinically it was significant. When you look at the change by EEG, there was a statistically significant change. Because of COVID during 2019, look at that. This is only 17 patients instead of 19, because a few of these patients could not come in to get their EEGs. However, once again, for the number of patients that came in to get EEGs, there was a remarkable decrease in EEG seizures. Were there side effects? Absolutely. During the blinded phase, patients had paresthesia, so tingling in the face, and some drooling. And these are the blinded candidates that have these symptoms. And then the unblinded candidates start having the same symptoms once they get turned on, which suggests that the paresthesia, drooling, fatigue, mouth contraction is really related to stimulation versus other things like headache, pain over the chest, weight loss. This was seen equally in the placebo arm as well as in the treatment arm, so suggesting that it is not related directly to stimulation. This is very hot off the press. So that's the end of that portion where I showed that EEG improves, seizures improve. That was the double-blind trial called the Estell trial. Now I'm going to tell you a trial called the ADVANCE trial. This paper just came out last month in the Annals of Neurology. This is a Toronto group that looked at patients that have VNS, vagus nerve stimulator. They have been optimally titrated up on VNS for a whole year, and the seizures have not improved. Now, the parents are given the option of what they call a partial randomization based on choice as to would they want add-on DBS or would they prefer to continue in the VNS arm. So let me explain this. These patients are 8 to 18 years old. They have drug-resistant epilepsy. They have had VNS for a full year. The VNS has been titrated, and there are no contraindications. According to the statistics that they had done, they were required just to have 6 patients in each arm so that they could have a powerful study. What did they see? The red is those patients that decided, no, don't want DBS additionally, we'll continue with the VNS. Their seizures reduced over the first 3 months from the start of the study by about 26%. By 6 months out, the added benefit was about 17%. And then by 1 year out, the patients that got add-on DBS to VNS clearly had a much better reduction in seizures compared to only about 17% in those that continued on with their VNS. If you look at the total in panel D, those that continued VNS versus add-on DBS, the number of patients that you have here that improved with continued VNS is only 3. Those that had add-on DBS, the number of patients that improved out of the 7, you have 1, 2, 3, 4, 5. So they had significant reduction in their total seizure frequency at the end of 1 year when you had add-on DBS. In panel E are the patients that said, well, we want to now open label go into DBS because maybe this didn't help us. So there were 3 such patients in this group that decided to have DBS after the fact. And 2 out of those had a remarkable decrease in their seizures. That's what panel E is showing you. So then I'm going to just touch on closed loop neuromodulation. Probably I don't need to talk much about this because Dr. Morel already did. But responsive neurostimulation is a closed loop therapy where it's an on-demand therapy that also allows you to record seizures. This is a study that I think she mentioned. I couldn't see her slides, but I suspect this is the study that she mentioned. 2 patients were with Lennox-Gastaut syndrome, had an EEG that showed a lot of paroxysmal fast activity, slow spike wave activity, and they underwent SEEG, stereo EEG, during their seizures, there is a generalized onset. This is just a network. There is really nothing that you can target individually here. When the patients underwent bilateral central-median nucleus stimulation, as you can see, this is the RNS device. These are the two electrodes into the central-median nucleus. In the lower panel, you see the seizures that are captured on the RNS system. And then TX stands for therapy. And within the first 3 seconds, they get treatment and the seizures stop. So this was a good example in these individual patients that were studied this way. So in the United States, I lead a special interest group, a subgroup of the surgery group, and we decided all of us are doing RNS in patients open label, and we decided to look across all our pediatric centers that are part of this subgroup to say, how many of you are doing RNS? How many of you are doing DBS? And we found that RNS in epilepsy has been in practice longer, interestingly, than DBS in epilepsy. This is pediatric epilepsy patients. But DBS has been in service longer for movement disorders. We found that the youngest child in this group that was implanted was 3 years old. And then we asked a survey of what makes a center choose DBS versus RNS. Was it the surgeon preference? And this is the graph. Was it the surgeon preference or the physician preference? Neither, as you can see. Was it evidence of efficacy in the literature? And it looks like a lot of us are looking to the literature to decide whether a patient should get RNS or DBS. However, a lot of times it depends upon what the insurance will allow. And it does not depend upon the fact. Some people think, the RNS reps come into the system and so we get great service and that's why we are doing more RNS versus DBS. And that clearly doesn't seem to be the case if you look at here. Sometimes it is the comorbidities of the patients that also will be a determining factor. There is much more to come. We are going to put together all our resources, all the patients that have had RNS retrospectively, and we are going to look at their individual data in terms of what parameters seem to work the best. Where in the brain are these electrodes exactly placed? Whether it is the anterior part of the central median nucleus, the posterior part of the central median nucleus, and then look at who are the best responders and what is it about their stimulation parameters that makes them respond so well. So whether it is going to be RNS, DBS, intracranial neuromodulation, extracranial neuromodulation, there is a lot coming up. Please stay tuned. Thank you very much.
Thank you so much, Charuta. It's really great that you were able to join us from remotely, even though you couldn't be here. We appreciate that. Was a fabulous talk, very, very clear. Any questions from the audience? I think we have time for one question. Just raise your hand. If not, you can email the questions to me and I can send them over to Charuta and she can respond to them if she's willing. I know she will. I'm just answering for you. Isn't that nice? But we really appreciate you being here. Thank you so much for a great talk. Bye, Dr.
Everyone.
Joshi.
Thank you.
We have one question.
We have a question. Okay, go ahead. Sorry about that. She didn't leave, did she? Okay, there we go.
It's not a question. Hi, my name is Chris Wood. I live in Denver, Colorado. My daughter was just implanted with the DBS, and I found your slide on how it gets decided and by whom for which device. And I just wanted to tell you that one thing to consider, too, is that as a caregiver, I'm usually asking that question, which device and how long, and I went to the Disneyland surgical track boot camp for that. But it quickly became most important to get my daughter on board because she is 19 and she does have opinions about her body and what goes into it. And so that ended up becoming a factor. And that's where all of my time and energy went. And so I'm just letting you know that's also in the what we can do, because I'm sitting here going, well, the insurers should be here too as part of that conversation if that's what's actually happening. But there are actual real people involved too. So I'm just letting you know that for your database, your mental database.
I think this is extremely important. And, because we were implanting in children that were like 3, 4, 7, that insurance question became really important because RNS is only approved for more than 17, as is DBS, especially into the thalamus for epilepsy, right? So I think that was why that was geared that way, not at all in any way or shape or form to not involve the patients here. And I think moving forward, we will definitely make sure that that is a specific question addressed. Thank you.
And I think a parallel survey, right? This is really how doctors are thinking about it, but how are we as caregivers thinking about it is a really important question that we can partner on. So thank you again, Dr. Joshi. We really appreciate it. And if there's any questions, we'll reach out. Any further questions?